This presentation is about understanding assisted living. Assisted living is changing the face of long-term care. My name is Benjamin Pierce, and for more information, you can visit my website at planetbenja.com. The growth of the assisted living industry has been phenomenal, from a fledgling $13 billion industry to now well over $100 billion. What's fueling the development? Well, there are opportunities. People are recognizing the opportunities from the baby boomer population. Also, family responsibility is shifting. There are more working women, more divorces, which results in fewer caregivers. And plus, there's decent margins in assisted living. But the risks are regulation, an increase in regulation among the states, which will it cost more to operate. The risk of having too much product because there's no certificate of need requirement to build. Risk of caring for a frail population in terms of insurance and liability, and also staff shortages. So what's the difference in the various different types of settings for elderly care? Independent living, the average age is about 78. It's more of a lifestyle move, and the residents are more independent. It's want-driven. There's 24-hour supervision there, but only one meal a day generally. Sometimes they have up to 3 meals a day. It's a concierge type of service. Generally, the apartments are full-sized with large kitchens, residential, and the pricing average is about $3,500 a month. Assisted living, well, your average age is about 83. They're in need of assistance with 2 to 4 of their activities of daily living. They seek out assisted living because they're becoming frail and their lifestyle challenges are becoming complicated. They're more need-driven. They provide 24-hour supervision, 3 meals a day, housekeeping, personal care. It's more smaller apartments with kitchenettes or small residential units with modifications. And the average cost is about $4,500 a month. Nursing homes, the average age is about 85. They need assistance with 4 or more of their activities of daily living. It's a high acuity, it's need-driven, and they provide 24-hour skilled care with 3 meals a day. It's nursing-oriented. Residents are dependent. They each have a room rather than an apartment. There's no kitchenettes. It's a medical model, and the average is about $8,500 a month. There's also home care. Home care is 80% reimbursed by Medicare. It's the location of choice by the elderly. Most people want to stay home and access care in the familiar own home environment. There will be increases in public support for home care as the cost of care increases with the volume of baby boomers accessing that care. But the providers will be paid less, and home care is extremely competitive. It's a limited business opportunity, though may be useful as a part of a network of elder care services. Nursing homes, while they're heavily regulated, they're subject to a certificate of need application. Most revenues are from public programs, Medicare and Medicaid, whereas many of the people who have private funds to spend prefer an assisted living environment. There's really been a leveling off of the demand for nursing homes as people seek to gain access to nursing services in a more residential assisted living environment. But if you build them, they will come. Favorable industry dynamics. Individuals 85 years of age and older, and millions, as you can see, it's going to double by the year 2020 from 1995. So as the baby boomers come of age, more and more of them are going to need care. There's also a flat supply. There's a flat supply in skilled nursing beds as more and more people are seeking assisted living as an alternate. Your typical assisted living resident is 83-year-old widowed female. She needs help with 2 to 4 of her activities of daily living. She's even more dependent on instrumental activities of daily living. Frequent reasons for the move include health, social services in a social environment, and also security. Average length of stay in assisted living is about 28 months. This is a chart that details the need for assistance of 85 and older population. As you can see, most people need assistance with walking and bathing, ambulation, and dressing, and fewer people need assistance with eating and transferring and toileting. This is the needs of assistance for people that are actually living in an assisted living community. Most people need assistance with medication reminder and bathing, which are two of the most significant challenging needs for elderly. This is the occurrence of Alzheimer's disease by age group. As you can see, more and more people, up to 50% of the population in the 85 plus cohort are at risk for Alzheimer's disease. Just a few facts about Alzheimer's. Alzheimer's disease is the most common cause of dementia. Up to 70% of the people have it. 1 in 6 women and 1 in 10 men who live longer than 55 years will develop Alzheimer's disease in their remaining lifetime. Alzheimer's is the 7th leading cause of death in America. The direct and indirect costs of Alzheimer's and other dementias related to Medicare and Medicaid and businesses amount to more than $150 billion each year. 10 million baby boomers will develop Alzheimer's in their lifetime. This chart details the etiologies for dementia. As you can see, Alzheimer's disease makes up about 70%, followed by vascular, multi-infarct, Parkinson's, Lewy body, and all other dementias. There are currently about 5.2 million people with Alzheimer's. As you can see, 5 million of those are older than 65, and about 200,000 are younger than 65. This number is expected to triple by the year 2050. Looking to the future, in 2000, there were an estimated 411,000 new cases of Alzheimer's. That number grew to 454 by the year 2010, and by the year 2030 to 615, and almost 1 million new cases a year is expected by 2050. The number of people aged 65 and over with Alzheimer's disease is estimated to reach 7.7 million in 2030, greater than 50% increase from the 5 million aged 65 and over who are currently affected. By 2050, the number of individuals aged 65 and over with Alzheimer's could range from 11 to 16 million, unless science finds a way to prevent or effectively treat the disease. By that date, more than 60% of people with Alzheimer's will be aged 85 or over. Alzheimer's worldwide is even a larger problem. 26.6 million people were living with the disease as far back as 2006. Researchers predict that the global prevalence of Alzheimer's will quadruple by 2050 to more than 100 million. 1 in 85 persons worldwide will be living with the disease. More than 40% of those cases will be late-stage Alzheimer's, requiring a high level of attention equivalent to nursing home care. Here's a list of common diagnoses for people entering assisted living: cardiac or circulatory, arthritis, CVA, cardiovascular accident or stroke, dementia, depression, diabetes, chronic lung disease, thyroid, cataracts, anemia, hearing impairments, by and large, cardiac, circulatory, and the mobility-associated challenges with arthritis and osteoporosis. Treatment. In assisted living, about average 2.9 diagnoses per resident. 35% have 4 to 7 prescription records, and 19% have 8 or more. Once they leave assisted living, where do they go? 36% are discharged to long-term care. About 31% pass away. 21% leave voluntarily, and 12% go to the hospital. These are some admission and discharges rule of thumb. A resident qualifies for assisted living when they are actively able to participate in 50% or more of their activities of daily living. A resident is normally discharged when they can no longer passively participate in 50% or less of their activities of daily living. Maximum of 85% disposable income should be applied to the monthly fee. And there's the formula. There's some risks associated with assisted living, particularly overbuilding in desirable locations, lack of regulations in some states, no franchises, limited public payment, risk of caring for dependent population in a less protected environment, underestimation or misunderstanding of developers of the business. This is a service, social, health, and housing. It's not a real estate play. Assisted living does, although, still have a big opportunity because of the demographics. Assisted living is a service-enriched housing for frail elderly focused on independence and dignity. There's different models, some unbundled services, some separate Alzheimer's sections or standalone into memory care units. Some charge premiums for high levels of care. From 2001 to 2007, Medicaid spending in nursing homes rose about 9.8%. Home and community-based programs rose 81%. So let's look at the different possible service delivery methods. First is the home health option, the service levels option, the point system, then actual care. Home health option segregates basic service package from the personal care component. You can deliver a high level of care, and there are Medicare benefits, but it must be separate and must be no duplication of services. But the operator does relinquish some of the operating margins, and efficiently should be able to produce 70 to 80% margin on loaded costs in the home health option. Service levels option. What they do is an initial assessment upon admission. They establish a base rate plus level assignment. And the levels can be level 1, level 2, level 3, or they can be basic, intermediate, enhanced, or comprehensive. Each level represents a progressively higher level of care. The disadvantages to this for owners are it's difficult to convince families to go to the next higher level, and it also tends to complicate rent increases if the service level needs to be increased at the same time as the rent. For example, an assisted living community that includes 45 minutes per day of personal care in the basic monthly service package may charge an additional $120 a month for their intermediate level, which provides up to 60 minutes per day. This can continue for each 15-minute increment to 240 additional per month for 60 minutes, 360 for 75 minutes, and so forth. Next is the point system option. The point system option establishes a baseline assessment to classify each resident's needs. They come up with a numerical score based on progressively higher levels of staff intervention. The scores can vary widely from 1 week to the next. As the condition change, generally care is already being provided without the recovery of costs. And there's a need for constantly reselling of the increase in the fee structure to the family. For example, here's a category, bathing and dressing. 1 point could be independent in bathing and dressing. 2 points could be require assistance only in transferring into and out of the bed or can bathe themselves. 3 points requires assistance in bathing and dressing, but they do most of the work. 4 points requires considerable assistance with bathing and dressing, and 5 points completely dependent upon staff for bathing and dressing. The next option is the actual care option. And I believe this is one of the best ways to do it. You get allocated a base weekly time limit, for example, 45 minutes per day or 315 minutes per week. Then a time study is conducted to determine if the individual is using more than 45 minutes per day. A service plan is developed, and then daily assignment sheets are created so the personal care aides can account for all their interactions with the resident and document their actual time. And this system is billed in arrears for actual care delivered. The actual care advantages, they only pay for the actual care delivered above 315 minutes per week. Management can recover its actual costs as the care is delivered versus convincing families to move to the next care level after the service is already being delivered. You get an accurate tally of the total staff needed to deliver the services, and it's much more efficient. It's somewhat similar to home health care. Now, when they do personal care staffing, there are several different staffing models you should be aware of. Universal worker, the rotational system, and primary care assignments. Universal workers, the employees are hired as care managers. They're cross-trained in several departments. They have responsibility for total care needs of the resident. Many stand-alone memory care units have universal workers. Management assists the care managers to provide a service-rich environment. Employees are hired at one specialty, then trained on others, and compensation can then increase with skill level and versatility. There's an increase in productivity and a decrease in FTEs, full-time equivalents, but it's somewhat difficult to hire and manage. There's a rotational system. The advantages is employees are trained on all residents. They have a greater flexibility, allows them some variety, gives them call-in coverage is much easier to arrange, discourages favoritism, and distributes workload evenly for heavy care residents. The disadvantage to that is residents are constantly reorienting new personal care aides, and the residents feel vulnerable. The older we get, the more heightened sense of vulnerability that we have. Also, when caregivers are rotated, there's a limited bonding with the residents. And because of that lack of bonding, there tends to be a higher turnover among the personal care aides. There's a less efficient cost tracking, and it's really impossible for people to recognize subtle changes in individuals. I think the best arrangement is to do primary care assignments. The personal care aide is assigned specific residents only. It's easy to track and supervise assignments, accountability of the service plan delivery. Residents bond with their caregiver. This is strongly preferred by families since they are dealing with the same nurses' aides every time they come visit. It's really the essence of quality care. Personal care aides recognize minor changes in the resident's health and can alert physicians or nurses to those changes. And also the personal care aides take a personal interest in their care recipient. Okay, there's several ways to calculate staffing requirements in assisted living. Can be based on minutes per day included in the monthly service fee and averaged, or it can be based on coverage in the building throughout the day, or based on ratio of caregivers to residents, or based on the actual care schedule. Here's an example of minutes per day by shift. Take the total number of residents, for example, 60, times minutes per day, including in the monthly service fee, say 45, which yields 2,700 minutes a day. And so they just allocate that by shift. So on the 7 to 3 shift, you'd have 3 persons, 3 to 11, you'd have 2, and 11 to 7, you'd have 1. Actual care based on assignments is another way to calculate it. You develop assignment sheets based on the service plan, schedule the minutes of service to each resident. Each personal care aide would have to perform 400 minutes of care per shift. You allocate by resident and shift. You schedule the residents for the care, and you increase your staffing with what is known as just-in-time staffing as you need it. 14 to 16 hours per day, you're actually delivering care. The rest of the time, the residents are generally sleeping. Peak time staffing for part-timers. You can bring part-timers in from 6 a.m. to 10 a.m. Also use 11 to 9 a.m., which is a 10-hour shift, to cover morning peak hours. It adds 2 hours to the night shift, but eliminates 1 4-hour day shift part-timer. Additional care cost recovery. The service plan is itemized daily assignments. The assignments are allocated to morning, afternoon, and night shift. The staff tracks the actual delivery of the care, the time that they spend. Additional care is only charged that exceeds the 315 minutes per week. That's the 45 minutes per day, even if a resident needs more or less on a given day. And here you get a nearly complete recovery of staff time. It all needs to be well managed. All time needs to be accounted for, including distractions, refused care, travel time. You got to watch for acuity creep and transfers as people become older, as they become more in need of care, then they need to be reassessed. You focus on residents' self-care ability to start or complete difficult tasks, manage expectations, try to keep them as independent as possible. You match employees to the job and not the job to the employees. It's important to audit the time cards against the schedule, the assignment sheets, and the budget for the department, and have proper supervision and quality assurance. Just a word on quality assurance. It really must be part of the culture. You must have a commitment to communicate the standards daily and painstakingly follow through. And access is limited in assisted living versus skilled nursing, because often in skilled nursing, the resident's door is always open. They're just in a room versus the residents in their own apartment with the door closed in assisted living. And it's important to take an offensive approach, systematically review and evaluation of the care plans on a regular basis. There needs to be an audit done regularly of the assignment sheets. The personal care aides need to partner with management and alert them about any changes in the health status of the resident, and also be aware that residents can become demented. Marketing considerations are really quite different in assisted living versus congregate or independent living. You're really marketing in independent living towards residents, extended decision time period. It's very value driven. It's a lifestyle focus. You use direct mail and advertising. Not necessarily 3 meals a day. And enrichment and activity programs are important, as well as guest apartments. Whereas assisted living, the approach is directed towards interested parties, such as adult families. The decision is generally quick. They're very need-driven. They're interested in services. There's mostly done through referrals, 3 meals a day, looking for specialized care. There's also respite available. So, there's a comprehensive way to market these using a media plan and your own staffing, direct mail, events, outreach, public relations, seminars, directory advertising, and collateral. It's all part of the puzzle that needs to be put together to provide a comprehensive marketing of the assisted living program. So in summary, there are many opportunities in assisted living, tremendous opportunity in elder care. It's not just a real estate play. It's a highly specialized service business to frail, vulnerable elders. There will be a need and a desire for more assisted living as the baby boomers become of age. May be overbuilt in some desirable locations, but there are underserved markets out there. The risks in caring for frail elderly in this setting, you just need to establish operational standards and training programs. In order to differentiate assisted living from your competitor, you just have to give customers what they want. And basically what they want is all-inclusive, individualized programs, family communication. They really don't want upfront fees, and they want a modest, value-driven monthly service fee. Each community is really a hub for senior education and peer networking, and it's important to provide superior service. And quality is simply the difference between what you expect and you give. And you give people a little bit more than they expect, and they give you a check in the quality column. Sometimes that's all you need to differentiate yourself from the competition. A little effort, a little more than what's expected, and they'll rate you as quality. There will be a need for rental senior housing for independent seniors who do want limited services. Hopefully this has given you a comprehensive look at the assisted living industry. My name is Benjamin Pierce, and for more information, please visit my website at planetbenja.com.